Hello, this is Craig Dale speaking, and I'm very pleased to present Word of Mouth, articulating text-based work processes in an institutional ethnography of mouth care in the intensive care unit. This is a re-recording of the presentation I gave on Thursday, September 25th, 2014, at the Center for Critical Qualitative Health Research. I'm very honored to have been recognized for my dissertation with an award for methodological excellence from the Center for Critical Qualitative Health Research, as well as being invited to talk about an approach to text that is distinctive to institutional ethnographic inquiry. My dissertation, like any other research project, was a collaborative effort emerging from the contributions of my supervisor, Dr. Jan Angus of the Lawrence S. Bloomberg Faculty of Nursing, and my committee members, Dr. Eric Michalowski of York University and Dr. Tasnim Sonaf from Sunnybrook Research Institute and the University of Toronto. I'm very grateful for their extensive direction and support. You know, I've also benefited enormously from the Center of Critical Qualitative Health Research for allowing me to have access to a community of support. As a doctoral student and now a postdoctoral fellow, I have taken advantage of the Center's speaker series, which has really opened up a large world of critical qualitative inquiry that I didn't know about otherwise. The Center's helped me to understand how others have addressed their research interests in unique and incredibly important ways, and how they've addressed the related challenges they've encountered during their studies. Now, much like the title of my presentation today, Word of Mouth, there's a lot to say about mouth care in many ways because there's great inequities that follow oral health and oral hygiene. But I'm also using word of mouth as a metaphor to suggest that important knowledge of everyday work practices often bypasses the official account. We do pass on critical or time-sensitive information verbally or through perhaps more direct demonstrations of our work, and this is certainly the case in nursing as it is in other fields, including research. With these ideas in mind, I've been talking today about text-based work processes and what I've learned about their powerful coordinative role in the intensive care unit. Here I'm talking about text as any replicable material that takes shape in paper. It might be some kind of form or paperwork that you fill out every day. It could be images on screens or electronic devices that you must read and respond to, and email and texting are probably things that people are very familiar with, and of course there's great urgency and pressure and a lot of work involved in responding to those things. And their capacity to reproduce and move across time and space that give them special capacities to organize our activities as well as our desires. So before I really open up my mouth on this topic, pardon the pun, I'll need to say that I'll be showing a few photographs from a different study that I'm conducting, as well as illustrations from various other sources in order to accelerate understanding about mouth care and the problems nurses encounter in direct practice. And although these photos primarily reveal mouths, of which of course you're all familiar, some of you might find their contents unpleasant. I therefore want you to anticipate these images and protect yourself as you see fit. So what I'd like to accomplish in my presentation today are to, one, offer an explanation of how I became interested in this topic of mouth care, two, a few words in terms of medical complexity and related forms of accountability relations that have taken shape in the intensive care unit today. I certainly want to talk about text in institutional inquiry and their importance therein, and therefore I hope to demonstrate how an institutional ethnographic or IE approach to mapping or following a sequence of texts led to some important discoveries about oral care that require new thinking and solutions. And finally, I look forward to hearing about your experiences, and I'll have my email address at the end of the presentation in case you wish to contact me. So in defining how I'm located in all of this, I think it helpful to disclose that I've been a nurse working in Canada for the past 20 years, and the vast majority of my career, 15 years specifically, have been spent in the adult intensive care context, looking after critically ill individuals treated with invasive life support technologies. And the main technology of ICU has been and remains mechanical ventilation. Now, over the course of this 20 years, I became fascinated with an increasing institutional fixation with the word practice. And these are practices that often relate to fundamental aspects of nursing the mouth and body. Now, this fixation became evident to me through an endless parade of new discursive entities such as advanced practice, best practice, evidence-based practice, and even practice guidelines. And of course, there's more, but I won't mention them because we'll run out of time. But of course, what these have in common is an urgent desire to improve clinical interventions and related patient outcomes, often by rooting out idiosyncratic practice variation through standardization. Suffice it to say that there's been a great deal of time and money invested in practice improvements in the intensive care unit because of the enormous costs relative to the size of the beds in hospitals and health systems around the world. So ICU care is perhaps the most expensive to offer in acute care services, and it accounts for perhaps 30% or more of the budget of most hospitals. Now, the emergence of evidence-informed textual products, such as guidelines, protocols, and checklists, they really form a distinctive feature of this new paradigm of practice. Whereas these texts are used to resolve some of the complexity of contemporary healthcare settings, my worry is that they often add a new layer of work, and they can stress us out a bit more, and they might not get at the underlying problem or worry that's surrounding this work. And so if we take a closer look at the mouth and its neighbors, we can see in this map that, surprisingly, death is in close proximity. Now, over the last few decades, mouth care has been vaulted into an unprecedented arena by scientific discoveries, of which I'll explain in a few slides from now. Suffice it to say that there's a new urgency to perform oral care to prevent problems in the intensive care context. These are new dimensions of oral care and oral health, and they're really kind of surprising and perchance unexpected if you haven't been paying close attention to what's going on in the ICU. Certainly, ICU nurses are well aware of this issue and growing accountability given their historical and contemporary role as harbingers of hygiene. Back in 2007, which is the year before I began my doctoral studies, I encountered this image alongside an article in the New Yorker magazine written by an American surgeon named Atul Gawande. He's made a name for himself as a writer of meditations on the problems of complexity as they take shape in modern healthcare settings. In this case, his story discussed how some 90,000 vulnerable and dependent people can be found in intensive care units at any given moment in the United States. These people rely upon the life support systems that ICUs provide, as well as the clinicians that work there to meet their every physical need. These are fully dependent people who cannot provide any of their own care. As an example of the intensity of these needs, he related a study stating that the average ICU patient requires 178 individual interventions per day, ranging from administering a drug to suctioning the lungs. So one can imagine that if a patient was very, very acute, there would be more interventions and perhaps more people around that bed assisting. Whereas the intervention he described offered clear benefit, he was explaining that their delivery via invasive technologies also posed serious risk. The main thesis of his article was that the risk of invasive ICU therapies often led to serious infections, which are enormously difficult to diagnose and treat. What's important about this point is that his suggestion was that the specter of these hospital-acquired infections can be attenuated, in part, through careful use of textual resources. As a panacea for uncontrolled infections and their growing social costs, he suggested textual resources could penetrate this tangled sea of complexity to save lives in a disordered set of accountability relations and serious illness. Here he argued that infections could be mitigated through standardized medical orders, checklists, or reminders for clinicians to activate scientifically proven infection prevention measures. And here within the red circle around the center of your screen, you might see a checklist under the arm of what's likely to be a physician exiting the room of an ICU patient. And what popped into my head at the time of reading this article and looking at this illustration were two things. The first was that the manner in which this topic was gaining traction amongst the public, this topic of hospital-acquired infection. And in many ways I felt this was leveraging or generating an anxiety about the safety and quality of healthcare delivery, and I wasn't really sure that this was helpful. The second issue was a problem of visibility. The topic of the day in ICUs, as it were related to infection, was pneumonia in mechanically ventilated patients. This was a huge area of research and certainly one of glaring concern as infections were beginning to be counted. What was happening in the background was that nurses were being asked to undertake new and intensified hygienic activities to prevent this pneumonia. So as I looked at the image, I noticed the absence of the nurse and the near invisibility of the patient. And I wondered about the accountability relations taking shape, how nursing work was being positioned, and what was really visible in this larger conversation to the public. I think what Gwandi and others have mobilized in their meditations on this matter was really a central problem of transgression in which the public was losing trust with healthcare. So over the past 20 or more years, health administrators as well as governments and private insurance payers had turned a spotlight on clinicians to rehabilitate their everyday practices as they were being perceived to ignore scientific recommendations for best practices. In some instances, these conversations were quite painful to read as clinicians were described as inept or in flagrant disregard of scientific knowledge in contemporary infection prevention, and Eric Mikulovsky has written on this topic quite eloquently. Now, the diagram on your right will be familiar to ICU clinicians worldwide, as it or a similar version circulated to explain a theory of bacteria translocation which explains pneumonia. Now, this theory states that oral bacteria accumulates in the mouths of intubated patients, and it begins to accumulate right away as soon as that tube is placed. And because patients cannot swallow, they can't even speak, they can't control their saliva, bacteria can be silently aspirated in oral secretions down into the lower airways to precipitate a deadly pneumonia. Now, the social and economic costs of this disease, of course, mobilize research and certainly a lot of professional society work to identify methods of prevention, diagnosis, and treatment. Now, in order to fast-track preventative care improvements, high-level organizations such as the Centers for Disease Control in the United States entered into this conversation in issuing detailed recommendations that including a new layer of textual products to clean up this problem. These included the recommendation for each and every ICU to create and employ a comprehensive oral health policy for intubated and mechanically ventilated patients. They recommended the use and documentation of topical oral antiseptics to control bacteria in each patient's mouth, the distribution of staff educational materials in the epidemiology of pneumonia and as well as its prevention, and of course an active infection surveillance program in each ICU. And so this was a considerable amount of work they were recommending. Now in Ontario, this was taken a step further in the creation of mandated public reporting of 8 patient safety indicators. This came into effect through legislation in the province in 2008 and included mandatory reporting of ICU-acquired pneumonia rates for each hospital. This proposed a new level of transparency and accountability through the display of rates of infection to the public. Now, aside from the pressure on clinicians that came with this, was the enrollment of the public in this effort to control the many burdens of preventable infection. So this is an interesting shift in the relations of infection prevention. This really got me thinking about accountability in the public in oral health historically. And as I undertook my coursework and was developing my doctoral proposal, it was recommended by Dr. Jennings that I take a look at the work of medical sociologist Sarah Nettleton. And this was good advice. Now, Sarah's critical ethnographic work warrants special mention as her research maps the manner in which the mouth, if you will, became separated from the medical body through the emergence of the dental profession in the late 1800s. But her work goes further as it shows how the individual, rather than the state, has been made responsible for oral health. In fact, she argues that women became special agents of dentistry in the state as they worked to minimize the occurrence of chronic and costly oral disease in the family. And these new epidemiological views at that time period really targeted children and household as a way to prevent illness throughout the lifespan. So through the translocal movement of newspaper, magazines, and radio media at the turn of the century, or rather the 20th century, dental care discourses entered the home to organize a large-scale public health campaign. In the first image on the left from 1919, one can see that dutiful toothbrushing intersects with general health and notions of good mothering. What's more, that text carries the type of message into the home that were to be messages certainly that were to be taken up as undisputed dental or scientific fact, as the magazine title itself suggests. Jumping forward in time to examine the advert from the 1940s on the right, one can see that oral health is connected to neoliberal and wartime imperatives, as a subtitle under Your American Duty says, to keep well and keep working. In both cases, I would say a productive tension ensues, as neglect of oral care can render one a recalcitrant citizen. Here we have notions of gender, science, and intimate personal hygiene emerging into a discrete set of practices that we know today as good oral care. This includes practices such as toothbrushing twice a day, flossing, regular dental checkups, and that means that people, at least in Western societies, primarily now retain their teeth, and this is a visible signifier of social accountability and adherence to expert forms of knowledge. And I'm certainly not discounting fluoridation here, but these are all part of the practices. Now, as I read the work of Nettleton and other medical sociologists, I began to think and realize that I was following a similar problem, but in a different sphere. The contemporary ICU image on the left of your screen alerts us that the work of oral care, despite its critical role in safeguarding patients, remains a female or nursing responsibility, and therefore very much a gendered assignment in its image. Notwithstanding the fact that changes in the oral cavity following endotracheal intubation could lead to death, dentists or other oral health professionals were not mobilized to assist the ICU team. Now, this image on the left is from a website of a pharmaceutical company, and it conveys to me commonly spoken ideas from the literature about oral care, and that is, in fact, that oral care is very simple or basic patient care. That is to say that the work itself is relatively unproblematic. As the image appears to say, patients are generally very calm and placid or passive, and this potentiates a kind of calm, comforting act of oral care, something that's very intimate in its execution. However, in my own experience, this idealized portrayal writes over what can actually happen in the space between the nurse and patient during oral care. And the image on the right, which is certainly a more informal photograph, tells us something else about the act of oral care, and perhaps that it's not so comforting. So accounting for this discrepancy, the discrepancy between experience and reality, became an important goal for my research, and I next turned to the literature to figure out how this bifurcation in experience could actually be happening. So the primary finding from my systematic approach to the critical care nursing literature revealed the constitution of a new discourse of oral hygiene. And in examining a wide swath, and 50 years specifically, of nursing literature, I was able to see how language addressing the purpose of oral care for intubated patients had shifted from oral comfort to bacterial control. This shift coincided with the emergence of new epidemiological language entering the literature in the 1980s, alongside a new discursive entity called ventilator-associated pneumonia, or VAP. So whereas there had been reports of pneumonia from the 1960s and moving forward, suddenly there was a new name and a new urgency to this problem. Now, in linking the critical care nursing literature to biomedical and social science concerns was the vexing problem of neglected mouth care. And neglect, of course, followed populations across the world in terms of its accessibility, or rather inaccessibility, whereas people could not get preventative care. And of course, their health and outcomes were very different accordingly. So this new discourse emphasized, in the ICU case, that transgression as professional and social expectations for nurses were shaken in the appearance of ventilator-associated pneumonia, certainly given the theory that it could be prevented with some mouth care. In short, nurses were accused of abandoning hygiene over time in order to prioritize more technical and exciting aspects of critical care. So to correct this matter, the textual resources that we've spoken about already, such as guidelines and policies, entered into the nursing literature to focus on large-scale corrections and interests that are certainly managerial in scope. However, this focus sustains what Nettleton calls a productive tension, and this is because the authorized accounts of care which primarily were evaluative, numerical, and epidemiological in their framing, generated quite a distance from the material practice of oral care. And what I found really disturbing looking at the literature, at least that by nurses, was the absolute lack of context-sensitive inquiry to produce close and abiding descriptions of this nursing work. There was just no qualitative work whatsoever, and people had not gone in and spent time with nurses to figure out what this work was all about. So collapsing this distance between the ideals of mouth care and nursing reality was something I wanted to do, and thus I turned to institutional ethnography for assistance. Institutional ethnography, or IE, provides really a strong methodological fit in terms of my interests and concerns as a critical, reflexive, materialist approach to social inquiry, and it offers the opportunity to move beyond abstraction to re-embody people, work, and certainly the context of those efforts. And implicit in this approach is an assumption that social relations, experienced as the routine or orderly activities of everyday life, hold together through extended forms of social coordination. As an innovation proposed by Canadian sociologist Dorothy Smith, IE requires an ontological shift towards the everyday. In this approach, people are seen as experts in their everyday locations, and inquiry always begins at the center of the action. And for me, this was really appealing. Now, although there exist many methods to follow and describe people's experiences and activities, IE departs from other ethnographic and qualitative traditions in its commitment to texts as coordinating media in everyday life. And following text at work, the institutional ethnographer can see how large-scale institutional imperatives enter into everyday experiences and practices. So in some capacity, it offers a unique way to stitch the micro and macro worlds together as they really do exist in people's everyday experiences. However, what really appealed to me was about institutional ethnography was the way in which it addressed a type of alienation I had experienced from my work. In this case, oral care had been commodified and proceduralized, the language had become very scientific, and it certainly wasn't recognizable to me as a material practice. Thus, IE opened an opportunity to take this work back, if you will, through a different kind of inquiry. So, the research study that I undertook began in a 20-bed, level 3 adult critical care unit at a university-affiliated hospital here in Toronto, where invasive and prolonged ventilation is provided to medical, surgical, and trauma patients. And level 3 patients offer the most intense and technological of care to ICU patients, so it's the highest acuity. Now, beyond a few pilot cases, the study proceeded with purposive sampling recruitment in 2 levels, as I was seeking variation in nursing years of experience, as well as interprofessional participants. First level participants were nurses, and 12 of them appear in the center table of your screen. And I accompanied these individuals in 4-hour go-along interviews during their care of a ventilated patient. Go-along interviews might be more familiar to those of you who read social geography, and they're a way of learning about something firsthand and in real time, all the while having the capacity to ask questions, if you will, as you proceed. And this was very appealing to me. In this case, the nurse was positioned as the expert navigator for oral care, and this experience provided me an essential first-hand account of the work, and I took copious field notes. I then followed up with each 12 nurse in a 1-hour semi-structured interview to discuss the events observed, as well as the documentary practices observed and the kinds of forms they were filling in and referring to, and I collected those and we talked about them, and they gave me a tour of those forms in those interviews. Now, the arrows and names in the adjacent table on the far right show how nurses provided referrals and recommendations to a second level of interprofessional participants, for example, physicians, physiotherapists, respiratory therapists, managers, and educators. And in sequence, this group offered up an extended network of interests, and in a way, I was interested in understanding the translocal relations of critical care, in other words, how their work hooked up with larger institutional concerns, as well as the work that nurses were doing in patients' mouths at the point of care. Now, by beginning at the bedside and spending time with nurses, this huge document called the nursing flow sheet became a pivotal document in terms of my understanding of what was happening. And I was able to see how the continuous work of nursing inscription within this document was of central importance to the whole operation of the ICU. This 24-hour record is a massive two-sided document, and if it's outstretched at the foot of the bed on a small table, it's probably as wide as the average person's arms outstretched. So it's quite large. And it requires hourly or more frequent nursing inscription and what institutional ethnographers call the text work text sequence, and pulling necessary data from overbed monitors, screens, medical devices, computerized laboratory reports, as well as direct care experiences. This work of inscription and filling this form in required a lot of physical movement, great attention, and certain areas were getting a lot of work, including vital signs, medications, physical exams, specific tests and therapies, as well as patient responses. So there was a lot going on in this form. And it created a kind of back and forth work between active patient care and its inscription. And you know what? This constituted quite a bit of time conflict for nurses. It was often difficult to prioritize both the patient's physical needs and this form. Now, one nurse described her earliest impression of being accountable to maintaining this central ICU text, and she said, "I do recall, when initial coming to this unit, being overwhelmed, even looking at the flow sheet for the first time, having the urgency of writing things down because of the other nurses, the rounds times, because of the doctors, because of the teams, and if you don't get it on there, it's probably more work for you as everybody comes to ask you." And certainly another nurse said to me something very similar, saying that when she was new, it felt as though 1 billion people were looking and grabbing at this form to garner information for their own work with the patient. So as I spent time along each of the 12 nurses, I too really felt the pressure they described to keep this document up to date because of its use during rounds, ongoing consultant review, and medical diagnostic workup. So if something important was changing in the patient's condition, as it often does in an unpredictable manner in the ICU, it had to show up here pretty close thereafter for it to be considered a fact. And nurses told me that if it wasn't documented, it didn't happen, or it wasn't completed. So this form spoke to nurses, and empty fields really were worrisome because it could indicate that they missed something. Now, amongst the many things that had to be documented in this form was hygienic activity. And so I had to go and think about the kinds of hygiene that nurses were demonstrating and experiencing in real time to think about how it might be recorded here. And let's do that next. So here's some difficult photos. Now, when nurses demonstrated the evidence-based oral care protocol, similar to the protocol that the CDC had prescribed, they showed me some problems that were quite interesting. Now, along the top row was a problem of access to the oral space, and barriers included swollen lips and tongues, excessive technologies crowding the oral space. There's multiple tubes, there's tapes, there's collars that prevent the chin from lowering and the mouth opening. And something quite interesting where patients were often, what they said, biting or clenching their teeth, and sometimes patients remained in this clenched state throughout the time of their care in their ICU, and this wasn't really well explained. During the opportunities when they could open mouths, even partially, to take a look, they were able to demonstrate a wide variety of serious conditions and patient needs, and these included advanced periodontal disease with gum and bone loss, advanced caries, which might be the dark areas you see on teeth at the bottom left, mucosal ulcerations mixed in there as well, certainly raw, irritated mucosa, an odd halitosis in neurological patients called neurobreath, which isn't in the literature and it's not well explained. And this would be a breath that would be, you could smell it from several feet away, and it required quite a bit of work, and it was quite resistant to solutions. And the bottom right corner, there is even a very unfortunate problem here of a bisected tongue, which resulted from ambulatory biting. So the patient has actually bitten through their tongue. It's bisected, and the yellow slough that you see is some of the scabbing or healing of that tongue. And so very sad. So these are some of the things that they encountered. So, but of course it's not all they encountered. When it came to the enactment, or kind of a longer sequence of care and doing the work, nurses showed me something very important about their patients' abilities to tolerate so-called basic oral care in the ICU. So I'm just going to pull out of the full presenter view to play a short video for you.
brush your teeth now. A little bit of brushing. You don't have any teeth. Stimulate your gums. Open up. Good. Okay, I'm just going to put some mouthwash in your mouth. Good. Doesn't taste too good.
So, as was the case in other patient encounters, nurses felt that many patients found oral care to be discomforting, if not outright painful. And I have to tell you that this was a very mild response from the patient, and that they seemed a bit confused, delirious, and certainly weren't enjoying the experience of oral care. So aversive responses by patients sometimes require the nurse to stop or abandon oral care altogether, and this is because patient agitation could become in fact dangerous. Arms would be grabbing out tubes and equipment, the endotracheal tube or breathing tube itself could get yanked, and if it was pulled out it could become a medical emergency that was life-threatening. So working around these responses required additional time and certainly skill. For example, nurses needed to talk or coach patients through oral care in a step-by-step fashion. Now, this might sound somewhat simple, but in practice it was not. And this is because patients might try to assert their needs during oral care, so the stop-and-go procedure. And patients would often try and mouth words, whereas they could not speak verbally, their lips could move very frequently, and they would try and say things to the nurse. So the nurse had to be very skilled in lip reading in order to understand what patients needed in order to proceed through this therapy. Now, when nurses showed me the section designed to record that activity within that enormous flow sheet, there was another surprise, and here's a blow-up of a small section where that would happen. And there was one box on a particular line, the third line down in this general care section, that was where it was permissible to code something around that care. Strangely though, mouth care, which might not be really clear to you in the pre-printed text here, was sharing space with eye care, so that suggested there was very little space to say anything whatsoever. What was really important to note from the key on the document was that there was no placeholders or coding to address the problems that you've just viewed in the prior two slides. This led to the requirement for nurses to spend extra time creating detailed narrative or handwritten notes in a different section of this form to explain the kinds of problems they were encountering and the patient responses to those interventions provided. So, notwithstanding this additional care and diligence, an ICU doctor told me that there are things that are written down in the flow sheet by nurses that are, again, the narrative component to care, which is clearly really important, but doesn't come off the page very well. And when I think a lot of the docs probably don't ever look at the narrative part of the flow sheet. So this data, and certainly this was not the only physician who told me this, it helped me to understand that there is a lot of time pressure in terms of reading and inscription work experienced by all participants in their ICU roles, and this inhibited a kind of collaboration and holistic understanding of patients' needs in the ICU, even needs that might have some important implications for infection. Now, in going back to that main document where this was all embedded, it was clear in talking to both nurses and interprofessional participants that certain stakeholders, and in this case physicians and managers, weren't really sure how oral care was accomplished. They actually hadn't ever really seen it, which was very strange. So this meant that they weren't certain how nurses applied oral therapies and resolved any problems they encountered. Nonetheless, they were really generous in showing me how their work was bound or linked to this large flow sheet as they continuously pulled data from it to inform their own unique documentary accountabilities. And these kinds of process interchanges were frequent and highly dependent on that nursing inscription work. So here I've shrunken the large flow sheet to the center, and you can see a series of documents in kind of a clockwise sequence with the data being pulled from it and worked up. So regardless of instead of infection prevention work being foregrounded as work got pulled out of this, it was actually an administrative set of texts that got pulled out in terms of looking for data that would work towards definitive diagnosis of infection. And as this moved forward through multiple forms, it actually left the hospital electronically and to produce Ministry of Health infection reports, including the VAP or pneumonia report that went online. So this was a really interesting link of intersecting texts and highly specific data moving forward for administrative ends. And so this is just one thread of textual interconnections that I pulled. And the nurses in the study unit were really actually put to work in this regard because they had to collect or pull some of this data themselves in terms of a secondary layer of nursing work, and they were involved in data collection, storage, and even cleaning this data before it got pulled into a Ministry of Health web data repository. Once processed by the Ministry of Health, this infection circled back to the hospital and key stakeholders such as the CEO who reviewed it, and there was a flurry of emails that would be going on in the background electronically around rates of pneumonia going up or rates of pneumonia going down, and this circled right back into the kinds of orders and processes that were happening in the unit and back to the inscription. So there was a kind of ideological circle always going on around maintaining the status quo of the prevention work based on ongoing reports of pneumonia. So while the surveillance was really well ensconced in a well-oiled machine, there wasn't very much attention to the prevention aspect of the work, especially the unresolved oral problems nurses encountered. This just wasn't highlighted in a similar manner. So when I asked nurses to describe the training they'd received in oral care, they shared not having been formally trained whatsoever. And recalling her undergraduate training many years before specializing in critical care, a nurse named Lucy identified, I have not really been, taught it formally, in a classroom or anything like that. I definitely learned from experienced staff. Although another nurse named Pat had attended a specialty critical care training course here in the province of Ontario that's endorsed by the government, she acknowledged a gap in that she wasn't taught. I just fumbled through it and I watched other people. In fact, what they were disclosing to me and what I realized over time that there was a hidden ICU nursing curriculum whereby more experienced trained nurses use their own good knowledge and experience to assist new nurses through informal mentorship. And this opened up my thinking about the manner in which nurses were resourced to proceed with oral health or preventative oral health activities. Now, as I spoke to the nurses, the clinical educators, and the managers in the ICU about the tools of oral care, they most often spoke of the sponge swabs and toothbrushes and the image on the left of your screen, which were considered the supplies for oral care. These were the provided things that would be on unit carts to employ in the mouths of patients. However, frontline nurse participants noted that these tools were often insufficient in overcoming some of the oral care barriers that you took a look at, including the oral crowding, the biting, the clenched teeth, or the aversive patient responses. Nurses had to work around oral care obstacles in employing a wide range of tools and sometimes fashioning new tools from non-oral care products such as syringes, catheters, and oxygen tubing. This was a really creative and important part of the nursing curriculum, and this functioned to keep some type of oral care moving forward at all times. Important to note was that this ingenuity was not recorded in the patient record or flow sheet that you looked at, as there was no documentary placeholders to capture this effort, and it was really hard to communicate all of this innovative on-the-spot activity. Now, as oral care opened up as an intensive practice in the ICU, it became apparent that textual ways of knowing and intervening in oral care, such as the surveillance work that was ongoing, had unintended consequences. As a method to penetrate the complexity of the ICU and render order, textual products such as forms, checklists, and the surveillance reports actually elided nursing concerns. And key ICU stakeholders that I spoke to had limited awareness of nursing difficulties. Moreover, they were uncertain whether patients found this care discomforting. They hadn't really heard of anything, and it hadn't come to their attention. Therein, an inversion of visibility followed this important work. Part of this low visibility likely related to the limits of clinical documentation. And this problem was aptly described by a nurse named Lucy, who noted that patient care record sustains a kind of disjuncture, as experiencing oral care is very different than maybe reading about it. Because the difficulty and time required to work around oral barriers and aversive patient responses was not easily recorded, the data that I collected suggested that the complexity of oral care in the ICU is indeed taken for granted. Based on the findings of my institutional ethnography and oral care, it's clear that mouth care in the ICU is fraught with challenges and important barriers. Despite a contemporary fixation on practice, certainly practices of infection prevention, some aspects of this work have been obscured. In my study, IE has been an important resource in foregrounding nursing knowledge and experience that has been excluded from a larger institutional conversation around infection prevention, quality, and patient safety. In this study, nurses experience frequent technical and contextual obstacles to oral care. This finding suggests that the complexity of performing oral care is underestimated, and this practice is perhaps undervalued. In comparing what nurses were experiencing to the local text, such as the medical orders, checklists, and documentary forms, and infection reports, it's clear that these resources offered limited technical guidance for the problems encountered. Now, since I undertook my study, international recommendations for oral care to prevent serious infections in mechanically ventilated patients have expanded. And from my vantage, they note increasingly complex oral care challenges ahead. In addition to the oral antiseptic chlorhexidine, which was the antimicrobial solution being employed in the study unit, guidelines now recommend selective oral decontamination with non-absorbable antibiotic pastes and gels, which need to be placed inside patients' mouths, generally between the teeth and the gums, to prevent respiratory infection. Because these are non-absorbable, it means they need to be taken out at intervals and the mouth thoroughly cleaned and then put back in. Now, these recent changes in expert recommendations mean that additional research is warranted to support nursing practice. Nurses really need new resources and strategies so that patients may fully benefit from these therapies if indeed they are effective in preventing pneumonia and the problems that follow. Because oral care is often complex and therefore requires additional time to carefully intervene, it's important to alert key stakeholders or decision makers, because they may inadvertently ignore this issue and the kind of time and skill that's required. Finally, the role and interests being perpetuated by techs in the ICU require careful consideration, as they may pose unintended consequences for patients, nurses, and the larger interprofessional team. In this study, efforts to deliver evidence-based care and undertake active infection surveillance appeared to organize attention away from the patient and active problems they encountered. Oral health is indeed inequitably distributed across societies, and the manner in which inequity is sustained, particularly in vulnerable groups, requires critical approaches to health and healthcare delivery to bring them forward. So that is the conclusion of my presentation, and I'd like to thank you for your attention and your interest in this topic of oral health and oral care in the intensive care field, and I'm more than welcome to, happy to receive your correspondence on this subject, and once again, thank you very much for your attention.